Welcome to the World Federation of Hemophilia panel discussion on adherence. We'll be talking today about two topics. One, adherence to treatment protocols, and number two, adherence to reporting on treatment with bleed diaries. I have five distinguished guests here with me today. On my far left, Pam Wilton, who is a respirology nurse and the mother of a person with hemophilia, so a caregiver as well, from London, Canada. Ed Kuebler, who is a social worker with the University of Texas Gulf States Hemophilia and Thrombophilia Center. And Kate Khair, a nurse consultant with the Great Ormond Street Hemophilia Treatment Center in London, England. On my right, Paul Wilton, a person with severe hemophilia A and von Willebrand disease. And to my far right, Gavin Finkelstein from Melbourne, Australia? Perth, Australia.
33,000 miles, that's fine.
Who is a person with severe hemophilia A. My first question is to Kate Khair. What is prophylaxis in hemophilia treatment? Could you describe it for us?
So prophylaxis is when patients are given treatment or give themselves treatment to try to stop them from bleeding. And there are lots of different treatment regimens around the world whereby you give lower doses or higher doses with increasing or decreasing frequency.
How frequent are these doses? Is it once a month, once a week?
Again, it depends on where you live in the world. So some people in the world start their children off with once a week prophylaxis. In my own centre, we're a bit more intensive with treatment and we start every other day. And most of my children get every other day treatment, and some of the adolescents have daily if they're very sporty.
And this is an intravenous treatment, so it's not
it's
just
it's an intravenous injection. Yeah, but of course the long-acting products that are coming might change the frequency that we have to give these products. And
could you just, in your own opinion, how important is adherence to these prescribed treatment protocols? Both in terms of preventing bleeding and also in long-term outcomes.
I think adherence, if we're going to call it adherence, I'm not sure I like that word very much, is really important. Because if you don't give the treatment, then it's not going to work. It's like if you fill up your car and you use all the petrol, you can't drive it anymore. You can't get anywhere. So we have to make sure that people with haemophilia treat themselves in an appropriate way, because that will stop them from bleeding and having the long-term problems with joint disease. But before even the people with haemophilia, we need to make the centre directors understand that to make people with haemophilia treat themselves all the time, we've got to stop them from bleeding. So giving very low dose treatment, not very often, and then bleeding is not really a good treatment regimen.
So I presume that physicians and the care teams give very precise instructions as to what the treatment protocol should be. Do you follow those instructions, Gavin?
I'm a different generation like yourself, David, so we didn't grow up with the benefits of prophylaxis, so we're more on an on-demand type of treatment. I practice prophylaxis when I'm away, so I'm protecting myself in that respect, but when I'm at home in Australia, I tend to just do it on demand or as need is. Sort of thing. So
is that what your doctor recommends, or this is what you've chosen to do?
We discuss it between the two of us, and this is what works for me. Every patient is different, as was being said before, and I think you've got to work out a treatment regimen that suits you. But if you start as a young child on prophylaxis, that is fantastic, and you continue it on. But having not had the advantage of starting with prophylaxis, I suffered joint damage when I was very young. So I grew up with very little product, so it's a different story these days. But I do prophylaxis occasionally, and when the need is most beneficial to myself.
We'll come back to the benefits in a minute. Paul, you're a younger person. You've probably been on prophylaxis your whole life. Do you follow your doctor's instructions?
Well, I haven't been on prophylaxis my whole life. Growing up, one of the recommendations from the clinic when I was first diagnosed was to only take the product when I needed it because of the concerns about the blood supply. And then from there, once we gained recombinant products in Canada, we felt more safe, and every 2 days I would take product as part of my prophylaxis regime. And that was something that I adhered to quite closely because it wasn't really my choice. Living in a two-parent house and having two parents, there wasn't much hiding if I hadn't taken my product that day. Also having a portacath, it wasn't something I could really self-infuse. So it was kind of when they were free and when they said it was going to happen, that's when it happened. And then we moved to the period of self-infusion when I learned to do that. And that's when my adherence began to slip a bit. That in some ways, I think a lot of it was memories of being a child and either being in the hospital and having them try 7 times to find a vein and they couldn't hit it, or being in the hospital, being in pain, and they're trying to poke you with a needle and you don't want it, so you're fighting tooth and nail and 6 nurses are trying to hold you down. So you kind of have those memories that don't make you too eager, or I guess you could say some psychological baggage that doesn't make you too eager to have that needle, even though you're skilled enough to do it and it's painless.
So as a young adult, you started playing with your own prophylaxis regime.
Right. I think I took the attitude that I still have a little bit now, that as much as we know what best practice is, I know my body better than anybody else. And I know what I can get away with and I know what I can't get away with. And we know what best practice is, but best practice takes discipline also, which we know that a lot of teenage boys don't have or are still developing.
So we'll come back to how to encourage this discipline. Pam, as a caregiver, Paul has said that he was carefully controlled in terms of prophylaxis. So is that a bit easier for a mother and a father to control that? Do you feel very disciplined in following those prophylactic regimes?
I'm not sure disciplined is the right word. I would say you have a huge responsibility, and it's that burden of responsibility that you carry. You don't want anything bad to happen to your son as a result of being non-adherent yourself, if you can call it that. And so with the responsibility of trying to do the right thing for your child, we would work out a schedule that made good sense to us. Now, keeping in mind our caregivers would recommend that you do this first thing in the morning. I don't know about other households, but when you have 2 adults rushing to get off to work and living in Canada where you open the drape and see that the snowplow has gone by and you have to shovel before you can even get out there, early morning doesn't always work well. And so, in fact, what we found, we looked at schedules, we looked at Paul's schedule, what was going on with the family. Sometimes it just made better sense that we would give the treatment after supper, just before we headed out to Cubs or to a swimming lesson, as opposed to that early morning rush time.
Ed, as a social worker, perhaps you could be the first one to attack this question. So is adherence a big problem in hemophilia treatment?
I believe it's a fairly big problem. It's a problem that I've been aware of as a social worker in a treatment center for the 16 years I've been in the community. We're always working towards adherence. At one point, I think it was compliance was the word, and I think we're looking for definitions. I heard a new word, concordance, which I like. It's more of the action to the adherence. So I think it's been a journey, and I'm not sure on numbers on how many. I think I've heard numbers of maybe 60% or 65% at any one time are applying when they're being measured to follow the regimen. And certainly there's a lot of psychosocial issues that go into that. Some of them just being stuck so many times or poked that then there's all this aversion to it, and it plays out within the family structure. So yes, I think it's a long time problem, and I think it's one that I'm glad to see there's a lot more, maybe a push again, focus towards it, that we have good treatment now, we have good care. a lot of countries, it's certainly the developed countries, but I think to bring that model forward even through the developing countries, if we can be the model and show that, once you have your treatments, it's going to be very important that you adhere or that you comply. And it's interesting, in developing countries, they're begging for it. I mean, it probably doesn't make sense when they look out into the world that, you have all that you need or you can play sports, and yet there's an issue with adhering.
So why would people with a safe and effective treatment not adhere to what their doctor has recommended? Who would like to tackle that?
I think it's because the doctor doesn't have haemophilia. And so as haemophilia treaters, we say, like Pam just said, you get up in the morning and you give your factor, and if you don't do that, you're non-adherent. And I really like the fact that Ed's just brought in Concordance, because that's about working with the family, working with the patient, and if for you it's better and easier to give it in the evening or on a Saturday afternoon, then doing that makes you adherent, if we're going to use that word.
Yes.
We're less likely to label you as non-adherent, and then you have a better relationship with your treatment centre, and you're more likely as a whole group of people involved in the patient's care to give that care.
Why would people not adhere?
I think we have to look at best practice sometimes versus realistic practice in someone's life. We know that drinking soft drinks probably isn't healthy for you. There's a lot of evidence to suggest that holding a cell phone to your head or holding an iPad for hours on end isn't healthy for you. And we do it because we either like those things or it's just such a part of our daily lives that there's kind of a trade-off between I'm willing to accept some risk or I'm willing maybe not to accept the best possible outcome because I'm confident that I can manage this in a way that I still end up with a pretty good or acceptable outcome.
I think you've got to add the aspect of it too when boys get to that age of 18 and they take on the responsibility of their own treatment regimen. They think they're invincible, they don't need this sort of thing. They haven't experienced many bleeds over time, and they become non-adherent during that period of time. Eventually they'll come back, but they need to experience, I think, a period of getting bleeds and thinking, okay, I can't survive without this, I'm going to change the way that I do things. But they have to come back to the party, and guys will always do this, is what we generally see, is that changing from the parental responsibility to the patient responsibility. There's always that period where guys have got to realise that I can't live my life without it. And the treatment centre has to be understanding of this, and this is where all the transition stuff and everything like that is absolutely critical. And you can't judge people. This is part of the rite of passage of growing up.
I think one part too to hit on Gavin's point is that it's kind of like everything else in a young man's life, that it takes time to figure out. And unfortunately, a lot of times, at least in the more economically developed countries, the catalyst is that you learn the lesson the hard way. My compliance now is certainly better than what it was before I had a few major bleeds and learned that I need to be monitoring this more closely.
Other comments on why people might not adhere to a
Yeah, there was a wonderful, I was listening to a presentation, and it may have been in the psychosocial pre-Congress, where someone really brought up the point, it's experience. One of the psychologists said, this topic, why don't you have everything you need, and yet you young men are not adhering, and you're not following the treatment and all the things we're discussing. But the person basically said, until I had the experience of a bad bleed, and it all made sense, and it was painful, it was personal, and it fit at the right moment, is when I decided personally to start adhering better, that those experts who have been working with me since I was a child, all of that made sense now in my life. So it was very, very powerful to hear that it was the experience and less about all the information, all the training. I think those things help, but it really, for that particular person, it really came down to, and I saw a lot of heads nod of patients. There's that moment when that happens.
So assuming that adherence to protocols is probably a good thing, though there may be a lack of research on that, but assuming it's a good thing, what are the strategies that would encourage people to adhere to treatment, and what are the strategies that might be discouraging? And I'll leave that open. Maybe.
Well, speaking as a nurse, a respiratory nurse, I try to, and I think I have the benefit of living with Paul and helping him to manage when he was younger. I always teach my patients who have asthma that you have to make your medication regime fit in with your life. It's one thing for the doctor to say you're going to take it every 12 hours, but you have to take your puffer at a time that makes sense to you. So if there's certain things that you do regularly every single day, you fit it in there. So you're controlling the medication rather than the medication's controlling you. And I think not that they need permission, but a lot of patients seem to think they need permission. The doctor writes a script and they feel, I have to do exactly what that script says. But when you give patients the permission to be flexible or discuss how that really fits and how that they can make it work for them so they're not forgetting and it's not too disruptive to the routine, it's much easier. Having said that, mixing up your factor, and we saw in a presentation yesterday where, sometimes you're mixing 6 bottles of factor. How does that ever fit into a routine? That's a little bit more difficult than taking a pill or a puffer. But also giving the flexibility to the patient and the family to find a time that will work best for them.
Kate, as a nurse, what do you think encourages people to follow your recommendations?
So I think it's about being bleed-free. As I said earlier, if our recommendations are that you do your treatment and you still bleed, why would you do your treatment? So it's about getting the treatment right for individual people, and it might not be every day for everybody or every other day. The dose might change. I think if we think about treating diabetes, we don't say it's okay for you to have a few hypos. That's not a problem. So we shouldn't be saying it's okay to have a few bleeds. We should be trying to make it individualised for people so that we can keep them as bleed-free with as few injections as possible.
But at the same time, they have to have had the experience of a bleed to know what the downside is.
Yeah.
Yes.
Mm-hmm.
That's true.
Your views on what encourages you to follow good recommendations?
Well, I mean, as we were saying before, and I agree with what they're saying, it's about that experience. If you experience a few bleeds, you go through the suffering, the pain of it, and the ongoing damage that would be brought on by that. So you learn your lesson. You learn the hard way, and that's the only way you're really going to adhere. I think it's just how young boys learn their lessons. You can't be told that you've got to experience it yourself.
And you don't have to learn that lesson 3 times a week, though, do you? So, you have a few bleeds and you've learnt.
Yeah.
So we should be then trying to get boys that have maybe fallen off the rails a bit back onto the rails to get them back into how they were when. Yeah.
And also, it's got to fit in with your life. And that's a really important thing. As Pam said, it's a part of your life, but it doesn't control your life. And that's really important because you don't want to be beholden to it. And you can work it so it fits in with your life, even if you've got 6 files to reconstitute at a time. You can have that 15 or 20 minutes downtime when you're watching TV or something like that, but it's got to fit in with your life. It shouldn't control it. That's how it would be, it's worthwhile, and that's where you'd be more adherent if it fits in with your lifestyle.
David, I think the other unfortunate reality is that if you've had a bad bleed or multiple bleeds and you've developed synovitis or arthritis, you're going to be compliant just to manage pain. That you're wondering if it's microbleeding, if it's arthritis pain, so you want to take the factor to manage that pain or to eliminate that pain. And if you have synovitis, if you've been given a protocol of taking 1,000 units every day or every 2 days, you are going to make sure you do that to prevent further damage.
I hear about from hemophilia treatment centers, good patients and bad patients. Could you talk a bit about the relationship between people in the center and the patients and how that affects adherence? Maybe perhaps Kate and Ed.
So again, it goes back to what I was saying earlier about how we label patients as non-adherent or bad patients for not doing what we tell them to do. And I think we shouldn't be telling them what to do. We should be working together. And then your bad patient becomes your good patient. it's all about relationships with the children, the young adults, the older adults, their parents, their family members. Wives are really good at nagging on their behalf,
And mothers.
and mothers. So yeah, it's about a team of people actually.
Ed?
Yeah, and I was thinking just a second, it has a lot to do with perspective. And I believe part of what, and from the psychosocial perspective, is trying to shift the perspective of the medical team as to how they're defining it. I believe in the medical model, adherence, everything is more scientific, proven. We need to show data. We need to be able to prove things. And when you're talking about a behavior and a behavior change and something that's subjective and so personal, those two collide often. And so you have the good patient who's adhering and is following all the regimen and those model patients. And then you have those that are just living life and trying to get through the other life crises and the other family issues and taking their medication on time, or taking it when the physician said it needs to be done, or the nurse. They become the bad patients. And I don't know that we always use those words, but it's implied sometimes is you're not being compliant, or you're not adhering to treatment. And honestly, that doesn't mean much to someone when you say it, other than to make them feel bad for letting you down. That's really that's all that happens. And then the missed opportunity of helping them engage in how can we make this so you're getting the best care with that.
Any final words to our viewers and listeners on adherence?
David, I just wanted to bring up another point too, that as a nurse, I sometimes have felt a little embarrassed about how caregivers sometimes treat patients. And so I observe that for clinics where it is the same people taking care of pediatrics, or some of the same people taking care of our pediatric patients and then moving forward into the adult, that sometimes those caregivers who have been taking care of that child since he was a little boy have forgotten that they're now a man, and they're still addressing the man as if they were a child. And I think that's difficult, and I agree that it's nice to have those long-lasting relationships with your caregivers, but I think caregivers have to recognize, I need to switch and treat him as an adult, and that adult patient now has to switch into a mode, I'm not here just to please you like a good little boy. I'm an adult now, and I need to make changes to the way that I do things. And so I think that's a difficult transition on both sides. The other thing that I think sometimes we can easily miss a reason why a patient perhaps isn't as adherent as we hope they will be. From a nursing perspective, the patients who do everything right are your easy patients. You get through your clinic faster and have more time to spend with the patients who need your help more. But at the same time, it's been my experience when I sit down and talk to a patient about why they're not able to use the action plan as we hope they would, or take medications as we hope. Sometimes when you take the time to delve a little deeper, you find out it's because those medications actually aren't working for them. And maybe there is something else going on. And I hate when we make assumptions, or we're too busy to sit down and figure it out. Maybe they can't afford it, or maybe they're fearful of a side effect, or maybe the home isn't a safe place for whatever reason, something psychosocial that's going on that they can't physically, they don't have a safe place where they can do that. And I think we have to just not say good patient, bad patient. We have to sit down with them and give them time to talk about what's really going on there.
I think another thing is that the national member organizations have a role to play in that it's not just about having youth activities where youth who are doing great get together and they have a bleed-free party. You need to make sure that you are inviting the older people who are affected, who maybe haven't had such a positive experience, because I think that really impacts the young people. I volunteer at a camp in Canada, and kind of, I think the unspoken knowledge is that it's good to have Paul there because all the kids see the way that he walks, and kids are very honest. So often I'll get questions like, why do you walk like that? And then a few years later, I'll hear them say stuff like, I make sure I take my factor so I don't end up like that too.
I think we'll stop on those words. I thank you very much for being part of this panel on adherence.